All right, welcome everyone. This is our fourth time this semester that we'll get a closer look. Today, we're really happy to have Jonathan Wenk from University of Kentucky give a closer look onto his work. I'm not going to read the entire title, it's a long title, but it's essentially on using MRI to learn about the mechanics of the heart, and specifically with one disease in mind. Jonathan is an associate professor, both of mechanical engineering, and has appointments at the Department of Surgery. Originally, he trained at Purdue and then went to Berkeley, spent a good chunk of time there, and then postdoc at UCSF with Julius Guccione, which is where we actually met almost 10 years ago now. And yeah, he promised to give us a nice, informal, broad overview over this project and where it's headed, as well as some results. I think with that, Jonathan, I'll hand the virtual microphone to you. And again, appreciate you being here.
Yeah, thank you so much for the introduction. So yeah, it's crazy to think back to when you and I met and sort of where we are now. It's kind of neat to see the evolution of people's career paths. You know, it's kind of cool. So I really appreciate the invitation to come give a talk at the Closer Look Journal Club. So yeah, you're right. My title is a little long, but I sort of believe in having titles that someone knows exactly what they're getting into when they read that paper. So I'm going to jump right in. And what I want to do first, again, I'm going to keep this pretty informal. So what I want to do is basically kind of go through how this project sort of came to be. And for those of you that actually went and looked at the paper beforehand, one thing you might have noticed is that it's actually a letter to the editor. So I've been interested in myocardial infarction for a really long time. Manuel mentioned my time at UCSF. That's where I really sort of started focusing on this work, looking at the impacts of myocardial infarction. But in the work that I did back then, you know, we were doing things with sheep. And so, you know, it's very controlled. You know, you have this sort of really nice way of getting a reproducible infarct. And obviously in patients, that is not always the case. And so a lot of the work that we did back then, you know, we were using MRI to collect a lot of data. And, you know, part of that was using MRI to look at things like strain. And then we would use that to sort of inform our finite element models that we were building to make sure that our models could replicate the strain patterns that we were seeing in vivo. And so, you know, when you stare at these strain patterns, you see that when there's a heart attack, there's a lot of weird things that happen, right? The heart isn't contracting correctly. You've got regions that are still normal, regions that aren't. And so you can kind of see this stuff embedded in these strain patterns. And so, you know, I reached a point in my career where I was like, you know, I'd like to see if there's a way for us to not just use this information for modeling, but truly just go directly with the information we're getting from MRI and see if we can make some kind of prediction about what's going to happen with these patients. So several years ago, so truly pre-COVID, this was 2019, I reached out to a really good colleague of mine, Steve Leung. Unfortunately, so he's an MD. It got dropped out in this little, this is a screenshot of the JMRI website. But so Steve Leung and Ahmed Abdellatif are basically cardiologists at UK. And I reached out to them because I knew that they were doing a lot of work that was related to infarcts. And I was like, you know, hey, if you guys have any MRI data that is in these infarct patients, I'd really like to sort of look at what's happening with the strain patterns in these patients, and maybe even see if there's a way for us to tease out some kind of information to make predictions about what's going to happen with them. And so as it turns out, MRI is not actually the standard of care for patients after an infarct. All patients are required to have an ejection fraction assessment, but typically that's done with echo. And there are a lot of patients that will go through an imaging sequence that's called late gadolinium enhancement, where you do use MRI, but you're injecting them with a contrast agent. And so it kind of alters the images a little bit. So you can see the infarct, but you can't necessarily extract things like strain. So it turns out that Steve and Ahmed had been doing their own internal study at UK for several years, where they were they were drawing blood from patients on a very regular interval after their infarct, trying to look for changes in inflammatory biomarkers to maybe see if there was something there about, you know, what happens to the evolution of these infarcts. And they were also collecting MRI in all of these patients. So long story short, pre-COVID, we look through the database and find that there's about 80 to 90 patients at UK that had a STEMI and had MRI data. And in a pretty decent chunk of those patients, they also had follow-up imaging, but not all of them, right? So some of them would actually go and get follow-up assessment with echo. So when we put this project together, we submitted it to JMRI, and the reviews were actually very positive. The reviewers really liked the work, but they were saying, your sample size isn't quite enough for a full paper, but we really like the work. We think that you're onto something here. And so the editor contacted me and said, hey, if you want to submit this as a letter to the editor, you can at least get this study out there. So that's sort of how this project came to be, was basically reaching out to my clinical colleagues about whether they had some data. They did. We did some really neat analysis, and I'm going to show you all the stuff that we did over the last about 3 or 4 years. All right, so a little bit of background on STEMI in particular. So obviously there's lots of different forms of heart attack. STEMI is particularly dangerous. And so what's kind of interesting about it, it's neat that, we've figured out how to use all of these different diagnostic tools to figure out what's happening with patients. So if you look over here at this EKG signal, so if you're familiar with what a typical signal looks like, the QRS complex is basically, you've got the Q, the R is this massive peak, and typically the S is all the way down here, right? It's pretty flat. So when a patient has a STEMI, which of course means ST segment elevation myocardial infarction, this ST segment is highly elevated relative to where it's supposed to be. And what this is an indicator of is basically if a patient not just has a reduction in blood flow, but this typically indicates that they have a full blockage, right? And that is extremely dangerous, right? So any tissue that is now downstream is not getting any oxygenated blood to it, and that tissue is going to die very rapidly. So obviously when a patient comes in, they want to do an EKG immediately. If they don't have a STEMI, of course, there's still a sense of urgency to help that patient. But if they see this elevation in this ST segment, they know immediately they have to intervene as soon as possible. Right. So in terms of the incidence in the United States, there's about 800,000 heart attacks that happen every year. 200 of those are recurrent heart attacks. Right. These are people that already had a heart attack and are now having another one. And basically about 40% of those cases are going to specifically be a STEMI. Right. And so what we want to obviously do is we want to make sure that we can get in, help these patients, and not let them actually progress into heart failure, because once they do, the 5-year survival rate is only about 50%. And so for those of you out there that are submitting grants, that are related to cardiovascular disease, this number right here is something that's been sort of a main sentence in a lot of AIMS pages for a long time, right? We have not been able to move the needle on this. Right. So the current standard of care, the 5-year survival rate has not changed in a while. It's certainly better than where it was, say, 50 years ago, but we have not been able to move the needle. All right. So what happens when someone has a STEMI? So the thing that typically is going to happen, they're going to go in, they're going to get an assessment. And once they realize, oh, this person has a full blockage, they basically want to go in and do a PCI, which is a percutaneous coronary intervention. So fundamentally what happens is an interventional cardiologist, they're going to get in there, they're going to use a balloon catheter, right? And they're going to do a balloon angioplasty, and they're going to go in, they're going to try and deploy a stent to revascularize that tissue, to really try and get blood flowing back to that region so that you don't have any more damage that's occurring, right? So that oxygenated blood is just critical to keep your myocardium alive, right? Without it, that tissue is going to become necrotic and die very rapidly. Right. So obviously you want to do this as quickly as possible. Now, for those of you that live in big cities, you have pretty quick access to a hospital. I'm in the state of Kentucky, and so we have a lot of people that are living in more rural areas. And because the University of Kentucky is the flagship of the whole state in terms of, healthcare, a lot of people from these rural areas are coming to UK to get their assessment. And so there's a measure that we refer to as pain to balloon time, which is basically as soon as they have the symptoms from a STEMI, how quickly can we get them into a cath lab and get them reperfused, right? So we want to do that as quickly as possible, but we can't always get in as quick as we'd like just based on where people are actually located. And so PCI has been really, really efficient. It's worked fairly well. It's the gold standard for what you do with a patient when they come in with a STEMI. But there's still a pretty decent chunk of patients that are still at pretty high risk of sudden cardiac death. And basically there's my clinical colleagues have told me there's basically this like 5-month window where there definitely there are certain people that are at very high risk for this to happen. Right. So clearly, if there was a way for us to really identify who are those high risk patients, then perhaps we can get in there and one, perhaps just monitor them more closely, or two, do something like put in an ICD or something like that to really make sure that we are taking care of these patients. All right, so currently the way that we go in and try and assess what is the severity of damage that has taken place because of this event. The sort of typical standards right now are doing something like a measurement of ejection fraction. A lot of times this is done with echo. You can look at things like microvascular obstruction. Late gadolinium enhancement is another way to basically go in and try and truly measure the size of the scar. So this is an example of an LGE image. So basically you inject this contrast agent, you wait about 20 minutes, and then this stuff is going to basically diffuse into that infarct region and really make it glow white to give you an idea of exactly where that region is. But when I say exactly, that is not truly the case. So there have been a lot of studies that have really shown that these techniques have some deficiencies, and they really aren't that great at predicting what's going to happen long term, right? So especially with something like LGE, they've actually found that it gives you a pretty decent assessment of how big the infarct is, but there are other circumstances that might not necessarily mean that what you're seeing truly represents scar. And so it's not always super reliable to use that information to help you sort of make a prediction. So the other big thing is basically you have to inject a toxic chemical into someone to be able to do that assessment, right? So right now, if you want to see how big an infarct is, you have to inject them with this gadolinium, which if someone has renal issues, that puts them in harm's way. And so anyone that actually has renal issues, they can't do LGE. So the idea of having a non-contrast approach to assessing someone's infarct is very, very exciting, right? So I actually want to give a quick shout out. So a friend slash colleague of mine, so Muriel Bansberger, who was at UK for a while, he's at Berkeley now. While he was here, and I believe he's still doing this work, he was looking at non-contrast options for assessing diffuse fibrosis in patients. And that opened up a huge set of patients that at the time really couldn't get any sort of contrast to help assess what's happening with their heart. So we can ditch the contrast and move to something else that's going to really be something that's important for the future. All right, so in terms of specifically looking at strain, there are some really interesting studies out there that have been done to use strain to try and sort of make assessments about what's happening with these STEMI patients. So typically what you'll see in the literature is this idea of a peak global strain, right? And so it's interesting, if you really go down the rabbit hole and you read these papers, sometimes it's not super clear exactly what they mean by peak, right? There isn't actually a uniform definition of what peak means. So for example, there's a set of papers where their approach is to basically look at the strain curves, right? So if you look over here on the right, basically you see an AHA bullseye. So I'm actually going to give a lot more detail about what this thing means in a little bit. And so what you can actually do in each of these regions, right, each of these segments, which is sort of meant to represent a region of the left ventricle, basically you can track what the strain looks like over time, right? So down here, what you're actually seeing is a curve representing the change in strain in each one of these segments over time. And these yellow dots are indicating where the peak value is. So regardless of time point, right, you basically traverse a curve and you say, okay, this is the largest value, right, in terms of absolute value, right? So it doesn't matter if it's negative or positive, you just look at what is the absolute value, largest magnitude along that curve. And so what they do is they take all of the values at these dots and they average them together and say, okay, that is my peak global strain. Other approaches take these curves and average all the curves together to get a single curve, and then they find the peak value on that single curve, right? So it turns out that that's sometimes kind of close to end systole, but not really. So there's actually different ways that people have tried to assess this peak value. But when you dig through the literature, what you haven't seen up to our study was basically no one had really thought of using end systolic global strain as a predictor in these patients. Right. And to me, it sort of made sense. When I think about contraction, I think about the systolic phase of contraction. If I want to try and assess what is the current state of contractile capability in the heart, looking at end systole makes a lot of sense. It's going to be a consistent time point between all of these strain values. And it's sort of the sort of, tail end of when the heart is contracting and trying to push the maximal amount of blood out of the heart. And so basically that sets up the goal of what this study was basically, okay, what if we use end systolic strain? And specifically, I was really interested in using the circumferential component of strain. And I'll talk a little bit about that in a second. So what if we use end-systolic global circumferential strain as our predictor, right? And then what we wanted to do is compare that to the peak global circumferential strain and LGE and see if we come out better, right? So that's sort of the whole goal of this study, was to really do this comparison to see if this gives us a better indicator of what's happening with these patients. All right, so now let me jump into some methods. So basically, we went through and we found, a lot of patients that had MRI data at that sort of initial baseline time point. But, not everyone had follow-up data. So in going through this, what we did is we said, okay, who basically satisfies the following criteria, right? So we looked back at this time frame when my colleagues were doing their study. We said, okay, so who had a STEMI diagnosis? Who had a PCI procedure? Who had MRI, right after they were reperfused? And was there any kind of follow-up imaging? So interestingly, some patients had both echo and MRI, but a lot of them just had echo. And so to make it consistent, we basically grabbed any data sets at follow-up that were imaging related to echo, just to make sure that we had, something there. And so what we did is we said, okay, of these patients, who has an ejection fraction that is less than 50%, right? So the reason we picked 50%, basically, if you're in the 50 to 55% ejection fraction range, you're kind of considered borderline in terms of having normal function. And so we wanted to really sort of separate, okay, if I have a set of patients that are less than 50%, I'm pretty much classifying them as being in trouble, right? They are below a sort of normal ejection fraction. And so we wanted to see if our approach could predict whether that set of patients would actually recover. And so we basically excluded any patients that had an ejection fraction that was above 50%. And so a quick side note, what's kind of interesting, all of the patients, at least in our study, that had an ejection fraction above 50% at baseline, they still had an ejection fraction above 50% at follow-up, right? So basically they had no change. They already had function that was, somewhat in the normal range, and they were able to stay in that normal range, right? Whereas the patients with an ejection fraction below, right, we had a mix, right? Some people did actually recover and some didn't. And we wanted to see if our predictor actually worked at telling us who those people were going to be, right? So at the end of this, we basically ended up with 31 patients that had all of this criteria. And so I realized that this is sort of results, but I kind of like showing it in the methods just to sort of give you some sort of breakdown of some of the key patient characteristics, right? So a lot of our patients were basically in their 50s, primarily male. Now, obviously, that doesn't necessarily represent all of the patients that are getting STEMIs. We do have a decent chunk of women that get STEMIs, but in our particular study, it was predominantly male. In terms of ethnicity, this does actually kind of represent the demographics of the state of Kentucky, right? So we had 87% were Caucasian and 13% were African American. And the thing I do want to highlight here is that all of these STEMIs were occurring in different vessels, right? And so to me, this is actually an interesting part of this study, is whether or not our approach could say, okay, regardless of where you have your STEMI, can we still predict whether or not you're going to recover from that? And so 21 of those patients, it affected the left anterior descending. 3 of those patients, it was the left circumflex, and 7 of them, it was the right coronary artery, right? So this mix of different vessels. And when I show the AHA bullseye again, I'll actually show you why they decided to segment the ventricle the way that they did. And it's very much related to these primary vessels. So our pain to balloon time, so I mentioned that a little bit earlier. The pain to balloon time was about 132 minutes. We had a couple of sort of outliers that were sort of very high. And I know for a fact that those people came from rural areas. And so it was tough for them to get to the hospital on time. We were able to image all of these patients basically within a day of their intervention. So as soon as they had that PCI, within a day, they actually were able to get them in an MRI to do that initial baseline assessment. And then the follow-up imaging was about 105 days. So about 3.5 months later, the majority of these patients had some kind of follow-up imaging so that we could see where their function was. All right, so giving you a very quick background on the technique itself that we use to assess the strain. So I will say that we used a commercial package. This is something that most hospitals now actually have. They use it for a lot of different things, not just for strain. They're using it for looking at things like ejection fraction. So here at UK, we have a software that's called CMR 42. It's by a company named Circle Cardiovascular up in Canada. And so what's really neat about this is, unlike, some of these specialized techniques like SPAM or DENSE or HARP or things like that, what you can do is you can just take regular old vanilla Cine SSFP MRI data, and you can do this feature tracking algorithm on it to extract strain. And so fundamentally, what our cardiologists will do, they'll go in, they'll segment the ventricle, right? They'll identify where's the epicardium, where's the endocardium. They'll identify the RV insertion points. That helps basically break up the ventricle so that we know how to break it up into the AHA segmentation. And basically within that sort of bounded region, you can then track what's happening to get these displacement vectors, right? So in terms of the algorithm itself, it's actually pretty neat. It's sort of analogous to, so they call it it's sort of analogous to PIV and fluid dynamics. So basically what you do is when you segment the ventricle, you're sort of identifying the region of interest that you care about, right? So we don't necessarily need to track what's happening out here. I just want to know what's happening right inside of the myocardium. And so basically what it'll do is it will create all of these regions and then break it into subregions and essentially try to identify, interesting features within that. So if you look at the red dot here, that's basically where that point is at, say, time point 1. And then at time point 2, looking at the exact same sort of fixed region, obviously the tissue is moving around within that region. We can see that the feature has moved over here. So it's truly just trying to identify interesting features and track where those things go. And then from that, you can get a displacement field. And for you solid mechanics people out there, we can then take that displacement and we can turn it into a Lagrangian strain. All right, so the AHA bullseye. So this is something that is really quite slick. So basically, what you do is you take the left ventricle and you basically break it into 16, sometimes 17 segments. I'll talk about that in just a sec. But the reason that the segments were sort of created the way that they were is that each of these regions is very much tied to a specific artery that is feeding the tissue in that region, right? And so what's actually kind of neat is when you look at these strain contours, right, these curves in time, just by looking at curves that sort of deviate from what's normal, you can immediately identify what the culprit vessel was in that. So you don't even necessarily need late gadolinium enhancement to even do that. You can truly just look at the strain curves and see that, right? So for example, this is actually strain from one of the patients that was in our study. And so we're looking at strain at the mid ventricle. So you can see it segments 7 through 12. So basically 7 is going to be at the mid ventricle, 1 is going to be at the base, 13 is going to be close to the apex. And basically, as you go around, you move from the anterior region to the posterior region, which is also referred to as the inferior region, right? And so you can see that different regions of the left ventricle are being fed by different vessels. So if I look at this particular patient, right, normally a circumferential strain curve is going to be negative. It's going to dip down because end diastole is our kind of reference frame. And so as the heart contracts, the sarcomeres shorten, you're going to get negative strain. You're going to get shortening in the circumferential direction, shortening in the longitudinal direction. And then you have positive strain in the radial direction because the wall of the heart thickens as it contracts, right? And so in this particular patient, you can see that segments 9 and 10 actually have positive values when we look at this sort of vertical line, which I'll explain in just a sec, is in systole, right? And so in theory, a normal healthy ventricle, all these curves would be peaking down here around, say, negative 25, right? But instead, these values are positive. And so if you look at this patient, right, segments 9 and 10, this person had a STEMI in their right coronary artery, right? And so just looking at these curves, you can kind of get a sense of where these patients were actually affected with their infarct. All right, so specifically looking at what we did, we said, okay, we want to have a global measure of strain, right? And so to make it global, I want to basically average together all these values in these segments to give me a single value, right? So whether we were talking about peak, whether we were talking about in systolic, you basically get a value of strain in each of the 16 segments, and you then average those together to get a single value, right? So in our particular study, the peak strain was taken to be the largest magnitude of strain, right, i.e. the absolute value regardless of time point. So again, looking at these curves, right, I've indicated with black dots where the peak value is along these curves, and clearly you can see that they're spread out all over time, right? Whereas this vertical line, basically when we're doing something like an ejection fraction measurement, the clinicians are already going in there automatically and saying, okay, where is end diastole? Where is end systole? Calculate my ejection fraction. So we just use that information to help us figure out where is the time point where we can grab the strain specifically at end systole for each one of these segments and then average them together.
Can I
Right,
ask a quick question?
Yeah, absolutely.
These strains, so you basically only have one scalar value for each region, right? So you said you're interested in longitudinal strain, right?
I'm doing circumferential.
Oh, circumferential strain. And then what about the transmural variation? What happens to that?
Yeah, so that's a great question. So
Sorry,
we did,
transmural meaning through the thickness of the wall, right?
oh
These
yeah, yep,
ventricles are like pretty thick, so
yep,
there is probably
absolutely.
some deviation.
Yep. So years ago, my group actually did some studies in rats where we were using dents and we were looking at transmural variations in strain. And so dents is a really nice technique for getting pretty high resolution strain. So to do transmural with the feature tracking technique, what we can actually get from it, because it's tracking essentially a curve on the endocardium and a curve on the epicardium. When I look at the report that I get from the CMR 42 program, I can actually get a strain in each of those segments that's an epicardial strain and an endocardial strain. But I've been told that when they sort of parse it like that, it's not always the most reliable. Averaging over the whole segment gives you, you're averaging over more tissue, and so you get a somewhat more reliable sort of value. Now, obviously, with a lot of these infarcts, they're not completely transmural, right? So a lot of the work I was doing when I referred to my time at UCSF, because we were doing a full occlusion in these animals, we were getting fully transmural infarcts. In patients, typically it's not fully transmural. So part of the wall might actually be scar, while some of it might still have some viable tissue. I would love to do something like transmural variation, but you have to have a sort of more robust, reliable technique for doing that. And so that's not to say that feature tracking isn't great. It's just, it doesn't quite have the level of granularity and accuracy that you get from something like dents. So in this particular study, we're just assuming this is averaged over the whole thickness, over the whole transmural thickness of the wall, and just getting a single value within each one of those segments. Does that answer your question?
It does. Really appreciate it.
Okay, no worries. Okay, so kind of wrapping up the methods. So I'm not going to show any cool, finite element models from this work where you get lots of, cool animations and pretty color plots. It's just a lot of statistics. So if everyone can stay awake for the next few minutes, I'm going to talk about statistics, which I know enough to get myself in trouble, but I had a really, really good statistician on this project. So for those of you that have good, reliable biostats people, you know just how valuable they are. So fundamentally what we did is we just did 3 separate logistic regression models where we used the late gadolinium enhancement, which is again, sort of a standard thing that's typically done, that peak global circumferential strain and the end systolic circumferential strain as 3 primary predictors, right? So 3 separate models where each of those was the primary predictor. And then after talking with my colleague, Ahmed Abdelatif, he sort of thinks that pain to balloon time is also a really good indicator of what might happen to a patient later on. And that makes a lot of sense. You can imagine if it takes a really long time for someone to get an intervention, odds are they've sustained far more damage to their myocardium. So we added pain to balloon time as a second predictor to those models. We did some receiver operating characteristic analysis to try and get some cutoff values. So this is not really pertinent here. I have a bullet point on it, but I'm not actually going to show the results. I'm happy to pull them up if someone wants, but whenever you report MRI results, it's really important to do an intra and inter-observer variability study. And so we did that with our study because, again, feature tracking is something that's kind of, it's been used fairly widely, but people are still, there's differences between the different software programs that are out there. So we wanted to just make sure that our results were reproducible. And so we did a couple of really thorough analyses to make sure that if I had 2 observers or just 1 observer that analyzed the data and then they went back and did it 2 or 3 weeks later, that we were getting the same results. All right, so hopping into the results. So I actually really like this figure. I think it sort of breaks down schematically a lot more what actually these AHA segments look like in terms of where you are in the ventricle. right? So if I'm at the base, mid-ventricle, apex, you can kind of see where the RV insertion points are, right? So this is sort of typically what the curves look like for a patient. So this is now looking at all 16 segments. For those of you paying attention, you will notice that there's a little 17th segment, which is exactly at the apex. Most people really don't use that. In fact, CMR doesn't report that because it's really hard to actually capture exactly what's happening at the apex, just given all of the motion that's happening. So we're really just focused on these 16 segments that are basically, you know, just above the actual tip of the apex all the way up to the base. Right. And so just looking at these curves, I mean, you can immediately see, you know, if a normal curve wants to be sort of down here where it's negative, you've got all of these curves that are being disrupted, right? So, and in this particular patient, right, segment 3 is being affected in the basal region. Segments 9 and 10 are being affected right in the mid, and then down at the apex, right, we've got segment 15. So again, this is a patient that had an infarct that affected their right coronary artery, and it's really affecting the inferior side of the ventricle.
Jonathan,
right, so
I'm still trying to orient myself a little bit. So
yeah,
is this the right ventricle, the sort of like white ear?
yes, yep, that is
okay.
Exactly, that's showing you the right ventricle. So basically this is going to be the septum.
Okay.
Right, so 2 and 3, 8 and 9, these are basically in the septum. And then this is going to be the anterior wall, this is going to be the inferior wall, and this is basically the free wall.
And then just
so,
for those that don't know the anatomic orientation of the heart really well, what's by the chest and what's by the back?
Yes, okay, so the anterior is going to be 1, right? This is going to be the part that's closest to the chest, right? And then 4 is going to be basically in the back.
And
right,
basal
so
is all the way toward your head, right? And apex is all the way toward your.
Yes, and the base, the base is up near the top of your chest, and the apex is going to be much lower. So yeah, think of the base as the top, despite that name, right? You might think so the base is the top, the apex is the bottom. The right ventricle basically is right over here on the side. And you'll see I actually have another plot from another study we did related to this work that kind of shows the influence of these RV insertion points, right? So the right ventricle attaches to the wall of the left ventricle. And so it really has an effect on what the strain looks like in those regions as well. It's kind of interesting. So basically for those of you not familiar with cardiac anatomy, I guess maybe 20 years ago, they came up with, they wanted to have a consistent way of reporting what is happening in different regions of the left ventricle. And so they came up with this AHA bullseye, again, keeping in mind what are the arteries that are feeding these different regions and what is the sort of right way for us to sort of break it up into pieces to say, okay, I have an issue in the septum, I have an issue in the anterior region, and so on.
And also just for those of you that are not familiar with it, the image next to it is actually the heart upside down, which
yes, it is.
like
yeah.
Super confusing aspect of cardiac anatomy and imaging. That often in echo data, the heart is flipped because that's how the echocardiographers see it.
Yes, exactly.
It's actually at the bottom. Just if you're as confused as me about this.
Yeah, no, thanks for pointing that out. Yeah, no, it's very true because with echo, it's all about where the probe is located relative to the heart rate. So what is that window that they're able to see with the probe? All right, so this again is kind of typically what the curves look like. And again, I always thought it was really neat to just be able to look at these curves and immediately say, okay, yeah, I know exactly where that person had a heart attack, right? I don't have to give them a contrast agent. I can just look at these curves and immediately see what region was affected. Now, granted, the point of LGE is to really try and quantify the size of the infarct. And I obviously get a rough idea if I know that, say, segment 3, segments 9 and 10, segment 15, their strains are perturbed. I mean, even segment 11 is sort of in a border zone region. And so it's hard to know how much of that is affected by infarct, how much of that is just because it's in the border zone. So it gives you a sense of general region where the person had a STEMI, but I couldn't quantify exactly the size of the infarct. But I still think it's kind of neat to just see these curves and be able to kind of know where they had a heart attack. All right, so basically looking at the probability curves, for those of you that are kind of familiar with looking at this kind of stuff, I mean, what I'm showing here, basically the probability of recovery, right? That's what we're trying to predict. Are you going to recover or are you not going to recover? So these dots at the top are the actual patients that did recover, right? So had an ejection fraction at follow-up that was above 50%. And then these dots down here are the patients that did not recover. And so right away, what I hope catches your eye with the LGE is just how spread out all of these points are, right? So we had a patient up here who from LGE, it looked like the size of their infarct, right, was basically like 50%. And yet that patient somehow had an ejection fraction above 50% later, right? So if I say, okay, what is my probability, right? So if I got a 50-50 chance, right? If I draw a line straight across here, right? Basically with LGE, you have almost the exact same probability of recovery or not recovery, right? You really can't distinguish who's going to recover and who's not. So when you get into the peak circumferential strain, global circumferential strain, things get, a little bit better, right? So again, these dots indicate who's going to recover. These are dots who are not. What you actually find when you do that receiver operating characteristic curve analysis is that if you basically just sort of draw a line at, what is my 50-50 chance of recovering, you see where that sort of intersects your probability curve. You drop that down, that basically kind of gives you what your cutoff value is going to be, right? So with peak global circumferential strain, things are getting a little bit better, but, still not great. But then we see with our end systolic, right, we're really getting a much better way of delineating who is going to recover and who's not. So there's a bit more clustering, right? So it's still not perfect, but when we really jump to the results of the ROC analysis, right, the things I want you to focus on, right, I have the cutoff values that we got, but when you see the sensitivity, right, and specifically if you really look at that area under the curve, right, so with LGE, the area under the curve was only 0.667, right, not great. And because that p-value was above 0.05, it basically indicates that this is not a good predictor of follow-up, right? This is something that isn't going to really give me useful information. With the peak global circumferential strain, right, we did get a p-value that was less than 0.05. And so this actually is a good predictor. I can see why there's a lot of papers in the literature that have been using this as a way of trying to look at patients after a STEMI, right? And the area under the curve was 0.8. But now when we jump to our approach with just using end systolic strain, right, as our predictor, right, we get a much better sensitivity and our area under the curve is 0.91. And when you do an actual head-to-head comparison, right, so we've got these sort of p-values that are giving us an indicator just of these three separate predictors. Are they going to give me a good assessment of recovery or not? But when you do an actual statistical head-to-head comparison of these different ROC analyses, we basically find that end systolic global circumferential strain is a superior predictor to the other two, right? So there is a statistically significant difference between the end systolic and the peak, as well as the end systolic and the LGE. And when you compare the peak and the LGE, there's actually no statistical significance difference between them, right? So this immediately is sort of showing us that this idea of end systolic global circumferential strain might actually be a pretty useful predictor. So when we then throw that pain to balloon time in there, rather than having probability curves, we basically kind of get surfaces, right? So instead of having, a value of 0 to 1 on that y-axis, what we have now is basically, right, here are primary predictors, right? And then here's that secondary predictor. Red basically is giving us a value of 1, blue is a value of 0. So you can see how the probability changes, right? And you can see the interaction of these two different variables, right? What happens if I say use peak and pain to balloon time? So same kind of story, right? Basically, LGE is kind of a mess. We're not really getting any strong prediction of what's going to happen to a patient. Peak gets a little bit better, right? So it's hard to pick a specific cutoff value here because there's an interaction between this pain to balloon time and these values. So you can imagine if you say, well, what if I go up to here, I could maybe use a pain to balloon time of say 10, and maybe I use a peak of about 12.5, right? What are the groups of patients that are actually recovered and which ones are not? But again, the more vertical these lines become, right, the sort of better off we are in terms of our predictive capability. So again, we sort of see that we're getting a lot more prediction, accurate prediction of these patients, right? So the red dots are the patients that recovered. The blue dots are the patients that didn't. If you sort of look at where that sort of 50-50 probability line is, we're seeing that we're getting a lot of those patients that actually did recover, and we're predicting accurately that they did. So again, instead of sort of tabulating it, I'm going to show the actual rock curves because we didn't pick out cutoff values here because, again, there's this interplay between the two parameters. But it's basically the same exact story. So even adding pain to balloon time as a secondary predictor in the model, basically it did not enhance the predictive capability of the LGE. Interestingly, the area under the curve for the peak did actually increase, right? So before it was 0.8, it went up to 0.829. So adding pain to balloon time made this a slightly better predictor. And it didn't really do much with the end systolic. It's basically the same area under the curve. But again, when you do that head-to-head comparison of the end systolic plus pain to balloon time, it still comes out to be a superior predictor to the other two, right? So again, the sort of summary of all of this is essentially, okay, we've got this really interesting idea of using strain to give us information about what happens to patients long-term. And so, trying to sort of build off of this idea of, okay, I know that Sidney images are something that's done as part of a standard of care, right? It's not all patients are getting it. Europe for sure is pushing on MRI a lot more in STEMI patients. Echo is still a lot more common in the US, but there are still these interesting studies trying to see if we can do stuff with strain that can give us long-term predictions of these patients, right? So basically from our study, we're seeing that this end systolic global circumferential strain is a really strong predictor of functional recovery in these patients. And it ended up being superior to these other two approaches that have been used previously, right? So to me, the really big power in this, if this gains traction, if this could somehow eliminate the need for doing LGE, you now have a much broader set of patients that you can use this technique on, right? So anyone that's got kidney issues, you cannot give them a contrast agent, right? So using something like strain as a way of predicting if these patients are in trouble, that could be really, really powerful. And so obviously my clinical colleagues are really interested in knowing, okay, who is exactly in this kind of state where we really need to track them more closely, right? So if you've got this 5-month window where you don't know for sure who's going to potentially have, an incident where they're going to have sudden cardiac death, ICDs for sure are a huge way to save that patient's life, right? So you don't want to just implant these things, sort of willy-nilly. You want to make sure that you are targeting the exact set of patients that need those. So hopefully this will really help us identify who those high-risk patients are so that we can have better monitoring. All right, so it's 12:15. I've got a couple more slides that I want to show. So this kind of wraps up the main paper that I wanted to present. But I mentioned that we actually managed to get access to a lot of data with MRI from these STEMI patients. And so we went back and we actually published another paper not too long after that first one, where instead of looking at global strain, which is averaging over the whole ventricle, seeing these regional strain patterns, there's definitely something very interesting going on there. And so what we did is we said, okay, we've got a lot more patients where we have MRI on them at that initial baseline time point, right? So we don't necessarily have follow-up data, but we've got MRI on a pretty big cohort of patients. And so what we did is we decided, okay, if we're going to look at regional patterns of strain, I want to make sure that there's at least consistency in where those patients had a heart attack, because I don't want to, average information together where if someone had a heart attack that affected one region, another patient had a heart attack that affected another region, I don't want to do any sort of statistical comparison of those things where I'm not doing it sort of, on a global scale. There, it was easy to average things together and not worry about those different infarct regions. Looking at regional strain patterns, we focused specifically on patients that had a STEMI in the inferior region of their heart, right? And so we still had access to this data, within 1 to 2 days after their PCI. Same kind of idea. We looked at a comparison of peak versus end systolic strain. We didn't have follow-up, but because we were focusing on that initial time point, that actually gave us 40 patients who basically had a STEMI in their inferior region of their left ventricle. And half of those patients had an EF above 50%, half of them had an EF below 50%. And we were actually able to access a cohort of normal controls, right? So these are patients that had an MRI of their heart, but did not have any sort of cardiac event to use as a comparison to see what those strain patterns look like. So I'm just going to do a single slide on this, right? So fundamentally what we're sort of seeing here, again, I'm pulling this figure in to sort of help orient everyone. So we're just looking at what's happening at mid-ventricle, right? So really interested in what is happening, right, in segments 7 through 12, right? So the black bars are indicating the controls. And what you can see is there actually is some natural variation from region to region as to what those circumferential strains look like. A big reason for that, if you look at segments 8 and 9, you'll see that they're right next to the RV insertion points, right? So that right ventricle attaching to the wall of the left ventricle really sort of augments what the strain patterns look like in there, right? Whereas when you look at segments 11 and 12, you see that they're more elevated and very similar to one another, right? Because those are away from that RV insertion point, sort of in the free wall of the left ventricle. But the key takeaway from this study was basically, when you look at the patients with an ejection fraction above 50%, what's really interesting, so the title of this paper was basically Regional End-Systolic Circumferential Strain Demonstrates Compensatory Segmental Contractile Function, right? So this compensatory effect. So patients who had an EF less than 50%, you see a pretty dramatic decrease, not just in the strains in that infarct region, right? So segments 9, 10, and 11, right? Those are basically the inferior region, right? The backside of the left ventricle. But you can see that in what we call the remote region, which is away from the infarct, the strains are actually quite low in those regions as well. But when you look at the patients with an EF above 50%, you see that the strain is actually elevated, not just relative to those patients with an EF below, but even relative to the controls, right? So there's this compensatory mechanism where those patients' left ventricles, the tissue in that region is actually trying to contract more to make sure that it's maintaining appropriate cardiac output. All right, so that was sort of a neat little study that was also utilizing some of that data. So this is my kind of last slide showing some of the work that's going on in my lab. So I've been really excited about MRI stuff for a while, but really trying to build these new techniques using just pure MRI data is certainly something I'm interested in. But at my core, I'm a finite element person. So my lab does a lot of work looking at finite element modeling of the heart. And so one of the things we're working on right now is actually developing new remodeling algorithms that aren't just looking at changes in volumetric growth, right? So there's a lot of work right now looking at changes in, the sort of bulk structure of the heart where, maybe the wall gets thinner, maybe the wall gets thicker, depending on what kind of hypertrophy I have. But in a lot of these different processes, whether it's an infarct or hypertrophic cardiomyopathy, the fibers themselves change their orientation based on what is happening right to that ventricle. So if you look really carefully at this little animation, this is actually one of our current simulations where we're actually able to put an infarct into a left ventricular model. So we take a region that's blue in this model, and basically the myofibers in that region are not contracting. And so what you're actually watching is not just changes in orientation of the myofibers, but also changes in the collagen orientation. And so what ends up happening is we're actually able to predict that when you cut off contractility in a region of the ventricle, the fibers become more circumferentially oriented over time, right? So this is not us assigning a value. This is us using our remodeling algorithm to actually predict what those changes in fiber orientation look like. And if you dig through the literature, you see that that's actually what happens with these sidewall infarcts is basically the fibers become more circumferentially oriented, right? So we're hoping that, this model could be used for something like, testing therapies to see if we can prevent adverse remodeling in STEMI patients. All right, so to wrap this all up, I clearly have to acknowledge, support from certainly funding sources and the people that have helped me with this work. So we've had a lot of support from the NIH over the years. I've been working a long time with a guy named Ken Campbell, so a lot of my finite element work is with him. These are the primary people. These are all the co-authors from the paper that I presented. So Stevie Leung is an absolutely fantastic clinician. He actually directs our cardiovascular imaging fellowship program. Richard Charnigo was the biostats person that helped us out. Teresa was one of the fellows in Steve's program that actually did a lot of the analysis for the strain. Mohammed and Elika are actually Ahmed's postdocs who are helping out with the study. And then Ahmed himself is just a fantastic physician scientist who I couldn't do a lot of this work without. And certainly I have to acknowledge my group. So my postdoc Curtis actually just left, took a job. I'm excited for him, but also very, very sad to see him go and also see his knowledge leave my lab. My PhD students, Hossein and Mohammed, have been instrumental in a lot of the growth and remodeling work that we're doing. And with all of that, I'd like to wrap things up and see if there's any questions. And real quick, because Curtis has left, I am looking for a postdoc. So if there's anyone out there that is interested in the imaging stuff that I presented or multi-scale computational modeling, please reach out to me and let me know if you're interested. And with that, I'll stop.
You did a virtual and a real clap.
Thank you.
Thank you, Jonathan. That was fantastic. A lot covered. I'm going to kick off some Q&A real quick. Some people will probably have to leave at 12:30 Eastern or 11:30 Central. But I'll definitely be a bit longer. There's already one question from Mitchell Colbank. I want to say one thing real quick. What I love about your study is that I think it shows how diverse biomechanics is and that it can span such a huge range of theory versus application. And I love that this is an example of using mechanics to really understand patients and disease.
Yep.
And I think many, including myself, haven't really translated their findings and their tools to clinic. And so I think that's really an inspiration to see you going from building very theoretical models and doing finite elements, including cars, and now really working at the forefront of clinical application. I love that about your work. And I think it's so important for students to see you can use biomechanics to actually make a difference. With that being said, Mitchell, I know you have a question.
Yeah, thank you. So that was a fantastic talk. So I really enjoyed that. So our lab here, I'm in Naomi Chesler's group at UC Irvine. So we're really interested in right ventricle, but we're finding, we're doing a lot of these studies where we're trying to understand, what's the crosstalk through the septum itself, especially in heart failure.
Yeah.
So I wanted to ask, are you finding, are any of your patients, developing, let's say, pulmonary hypertension due to left heart failure? And or are you seeing any features or are you looking at right ventricular strain or any sort of changes in right ventricular strain that might be able to map some of these other outcomes that you're really interested in?
So those are fantastic questions. So first of all, I am very aware of the increased mortality that is associated with pulmonary hypertension and with right ventricular heart failure. I mean, the right ventricle is so incredibly sensitive. And so it's actually interesting you're asking this because I asked my colleague, Steve, I was like, is there any way that we can do analysis of the RV? And the answer is maybe. The right ventricle is a lot thinner. It's a little harder to track. In patients, it's not as bad. You can see it pretty well. I know that for sure in like animal models, we've done a lot of work with mice and with rats, and sometimes tracking that right ventricle can be a little bit tricky. So to sort of go through your questions, I am interested in seeing if there's a link between if any of these patients went on to have any issues with their right ventricle or not. We haven't gone through that data yet. So we have access to all of these patients' medical histories. And I know they were tracking a lot of these patients with follow-up for a while. So obviously to know whether they really developed those issues, we have to have that sort of longitudinal data on them. So I'm actually gonna write a note to myself because you're making me want to go back because I asked about looking at right ventricular stuff and it's something I'm very interested in. So I don't have that data on these patients right now, but I think it's something that we're certainly interested in doing. And I'm hoping that we've continued to track these patients and we could know, when they were imaged, because this was between 2014 and 2019. So if we still have data on these patients, we might actually have a really nice longitudinal follow-up to know if they developed any issues. We could go back kind of retrospectively and see if there were any indicators in the left ventricular strain patterns about whether that's telling us whether they're going to have right heart issues. But we also want to see if there's a way to do that strain analysis in the right ventricle. I know that other techniques might be a little better suited than feature tracking, but it's something that we're kind of toying with how we're going to go about actually trying to assess that.
Yeah, awesome. Thank you.
Connor, I think you have a question.
Hi, yes, thank you. Great talk. I'm a PhD student in Craig Gorgen's lab at Purdue and really interested in this work. And one thing I was fascinated by with your results is the differences that you saw, the temporal differences between end systolic versus peak strain values. And I guess my question was if you've had a chance to look at strain rate or if you would suspect temporal differences or maybe that being a an indicator of kind of that shift that you're looking at?
Yeah, no, that's a great question. So there's actually, there are a few papers out there that rather than focusing on primary strain, they were looking at strain rate and trying to see if there was predictive value in that. So I think that there is some really interesting information to be found in the strain rate. I will say that when you're doing MRI, I mean, I like MRI better than echo, but I recognize that echo has superior temporal resolution as compared to MRI. So I sometimes am hesitant to look at strain rate data from MRI if that temporal resolution isn't something that I think you can really capture some of these subtleties. So I think there is really interesting information in the strain rate. Echo, it's tough. So if you really dig into the literature, in order to get predictive value from echo, you have to have a lot more echoes that you've collected to be able to get like the right statistics. Whereas MRI, you have much better sort of spatial resolution. And so it's like, if I'm trying to do a big cohort study, I need a lot more patients with that echo to be able to build up, okay, what are the actual, say, maybe cutoff values that I need to distinguish between patients? So it's sort of a double-edged sword. Echo is going to give me better temporal resolution, but I don't necessarily trust the data that I'm getting from the speckle tracking as much as I do from MRI. So I think there's something there. It's just a question of what's the right sort of modality to tease out that strain rate information. That's something I'm still kind of thinking about myself.
Definitely. Yeah. Thank you.
Yeah.
Any other question by anybody? Matt has a question.
I have a question.
Yeah.
And it's maybe two disparate questions, but I don't think that either of them will take very long to answer. So the first one, I'm sort of curious about the processing time. So like how long does it take to get these measurements once you have the images in hand? Sort of from the perspective of clinical translation, how quickly could you get this information if you needed it very quick?
Yeah, so it's actually quite quick, especially if you have a highly trained MRI reader. So Steve he's a level 3 MRI reader. And if I get him a data set within, I kid you not, within 10 minutes, he can have this thing analyzed. I mean, it's very quick.
Oh, wow.
I mean,
Okay.
and again, we did an inter and intra observer reproducibility study. I didn't show those results, but it is very reproducible. And so someone asked earlier about, if I was looking at longitudinal versus circumferential, there are a lot of papers out there that have looked at longitudinal strain. Interestingly, in our patients, we found that the longitudinal strain wasn't quite as reproducible. And so we really just focused on the circumferential. But when he does that analysis, you get everything. You get longitudinal, circumferential, radial, you get all components, because once he traces those contours, the algorithm basically tracks in all directions and gives us that report. So it's actually pretty quick. So there's a lot of clinical value in that. And that's why a lot of places actually have these feature tracking programs now. Some of them are sort of tinkering with them, but you can still get things like ejection fraction, other sort of typical clinical measures with the program, as well as the strain.
Okay, great. Yeah, so in that answer, you actually answered my second question, which was going to be why you chose circumferential over longitudinal, but you've already answered that. So
yeah, and it's
way,
that. Yeah, that kind of surprised me though, because there are a lot of papers that have shown really nice results with longitudinal. And so I haven't really had a chance to dive into why our results weren't as reproducible as what other people have reported, but the circumferential for sure was very robust and gave really good results no matter who was doing the analysis. Because we had level 1 readers help us with the inter-observer, and then my colleague, who's the level 3, did the intra. And if you've got a highly trained person, they can go in and go through this stuff very quickly in a reproducible way.
Great, thank you.